going to jump into when we start talking about communication. Before we start talking about communication, we wanted to make sure that everyone was operating from the standpoint of a clear understanding of what the screening requirements are. So just quickly going to give the details of the screening requirements and then move into the communication to support the requirements. Next slide. And so this is a quote directly from the rules, from the final rules that mandate where we move to hospital mandatory reporting of screening, where CMS stated that their goal is that there's screenings and that the health-related social needs screening will be a requirement that's part of discharge planning. And since it is something that is an expectation that is part of the discharge planning process, just the noting the obvious in the bold and the red at the bottom that discharge planning begins on admission. And so if we're establishing the fact that we're completing the screening and that screening is part of discharge planning and discharge planning begins on admission, then the connection to community resources should also occur very much upstream and be part of realizing the needs on admission and begin planning the connection to community resources also on admission. Next slide. So the actual numerator and denominator for the required reporting. So if we start on the left part of the screen, there's the screening for social drivers of health, or SDOH, which is the number of patients admitted in the numerator that are 18 and over on the date of admission, that are screened for health-related social needs. So this is a global requirement with an expectation that we're screening everyone that hits the door that's 18 and over on the day of admission. And so the numerator is the number of people screened compared to the number of people admitted. The reporting is by domain. And so there's 5 domains that are listed at the bottom: food, housing, transportation, utilities, and interpersonal violence. And so we are reporting the percentage of persons screened versus those admitted, and we're reporting per domain. And then the next part of the requirement on the right side is the screening positive measure. And that screening positive measure is a number of patients admitted who had a positive screen in each domain compared to the number of patients who were screened. And again, this is an annual reporting requirement. It was voluntarily last year. It's mandatory this year as part of the hospital quality reporting requirements. And now you're having to report both the screening measure and the screen positive rate. And when we're looking at globally, everyone that's admitted is over 18 to meet this requirement, then you can really begin to see how these handoffs to community partners become ultimately more important as we're increasing the volume of the screening to meet this requirement. Next slide. So now that we're talking about the importance of communication and clinical handoffs, we're going to go briefly into a section of team steps. So if you're familiar with team steps, next slide. Team steps is an evidence-based tool around training for clinical handoffs and communication within clinical teams. There is now Team Steps 3.0, and it is something that was developed by AHRQ. There's the link. An actual Team Steps training session is a minimum of a half day. So we're in no way doing justice to the entire Team Steps training module, but we are just going to pull out one aspect of Team Steps and present you with some of the tools. And these are all evidence-based tools that can improve communication. And so we're going to focus on the communication aspect of Team Steps because of its application to the screening requirement, now that hospitals are going to have to meet this requirement to ramp up the screening for social needs amongst the population of patients admitted over 18. Next slide. So in Team Steps, and this was a slide directly from the Team Steps training, that it really highlights the importance of handoffs, and handoffs should occur during transitions and in care across the continuum. And so in the instance of screening for health-related social needs, identifying persons who have a positive screen in one of the 5 mandatory domains, with the expectation that there's this handoff to community partners, then we should be following the evidence in terms of the handoffs. And since this is all part of discharge planning, this process begins on admission with this link to community partners with a quality handoff. And see the bottom part of the slide where they define what are the elements in a handoff. And so that transfer of responsibility and accountability. So this person has now been screened positive for health-related social needs in one of the domains. The discharge planner has now connected with a community-based organization, and then the handoff occurs. And the elements of that handoff should be the transfer of responsibility. So from the discharge planner to the community-based organization should be clarity in the information shared, should be verbal communication of that information, acknowledgement by the receiver. So in this instance, if we're handing off to a community-based organization, there should be this exchange of information and acknowledgement of the receiver, the community-based organization, that they've received the information and now going to work to address the needs that were identified during the hospital stay, and an opportunity to review. So that usually means that once that they've received the information, they have an opportunity to ask questions, as well as a process for bidirectional exchange of information. Once they engage, if they need to then identify additional issues that were found after the community has engaged this person, a pathway to extend that communication back to the clinical team who handed it off to the community-based organization. Next slide. So the SBAR is the framework for effective communication amongst team members. And in this instance, we're really highlighting the handoff from hospital to community-based organizations that are partnering. And so we should be following the same evidence of appropriate communication. The steps, what is the situation, or SBAR is the acronym. So the situation, so what's going on with the patient? Patient was admitted. We completed a health-related social needs screen. We found that they had a positive screen, meaning there were some social needs in one or more areas. And now that situation is being presented during the handoff to the community-based organization. Background, so the clinical background and the context. So in all of these things, we're really looking at health-related social needs. So social needs that have a direct impact on the ability to treat the health condition. So this background should be providing that linkage between the social need and the admission. The assessment, so what is the crux of the problem? Sometimes when there are social needs identified, like housing insecurity, there's a contributing factor to the housing insecurity. And so if there was any information that was obtained during the screening process, during the inpatient stay, then this information would be shared as part of the assessment. And then lastly, the recommendation. So what would be recommended and what would be needed of the community-based organization that's partnering. And this process would not obviously occur on the day of discharge, but we would want to get as far upstream as possible. Ideally, this communication would begin on admission as we're finding the needs and we begin planning for the discharge. We also begin planning for what are the resources that are going to be required to address the social needs so that we can have the continuum of care extend from hospital to community in a seamless manner. Next slide. So with this expansion of screening, with the magnitude of screening for the entire population of persons admitted over 18, and then documenting and reporting those that had a positive screen, this handoff to community also must encompass just exactly how this can be sustained. Because if we begin identifying large volumes of persons who have social needs that need to be addressed as part of the discharge planning process, there needs to be a pathway for sustainability. for the community-based organizations that are going to be working in partnership with hospitals to address the identified needs. So that's really important in order to support scaling. As community-based organizations will have to scale to meet the volume of needs that are identified as we move to this instance where there's broad screening. One potential pathway is, and we'll be going into much more detail, is in the calendar year 2024 physician fee schedule, CMS introduced reimbursement for two new categories of care management, one called community health integration, the other one principal illness navigation. And both of them have a specific category for services that's reimbursable that includes supporting transitions of care. And so we'll provide some additional details, but that is one pathway for sustaining partnerships between hospitals and community-based organizations that leverages reimbursement. And that's reimbursement is specifically for addressing social and other needs amongst the population that have a recent hospitalization. Next slide. So I'm now going to provide much more detail about these two new sets of codes and what are the requirements. Next slide. So as I mentioned, this is new, all beginning January 1, 2024. It is a Part B benefit for Medicare beneficiaries, and there's already interest in some states that are looking to align Medicaid policy to these rules. But essentially, CMS established a new set of HCPCS codes or billing codes, and the billing codes reimburse Part B providers for the labor expended by auxiliary personnel such as community health workers. And it also allows for providers to contract with community-based organizations such as area agencies on aging that provide the labor to address social health-related social needs amongst the population. The key aspect of the rules is that the social needs that are being addressed must significantly limit the practitioner's ability to diagnose or treat a health condition. So it's directly tied to health needs. And when labor is expended to address those needs, then it's reimbursable. Next slide. So here on the slide are the categories of services that are reimbursable. These are time-based billing codes. So the Part B provider can have auxiliary personnel or contract with a community-based organization that provides the personnel. When there are identified social needs, the social needs must be included in the problem list. And then when the services are being delivered, they're capturing the time, and then it's reimbursable based on the time. It is a Part B benefit, so the co-insurance or deductibles do apply, but if a person has a Medigap policy, or if they're dual eligible and have Medicare and Medicaid, Medicaid becomes the gap plan that covers the cost sharing requirements. Next slide. These are the reimbursement rates. The rates listed. This is the national rate. There is some variance or modifications based on your geographic location, but this just gives a framework to show how the reimbursement occurs. It is time-based billing, so the reimbursement occurs for the totality or the aggregate of time spent addressing social needs during a calendar month. The first code, G0019, it reimburses for the first 60 minutes that were spent by auxiliary personnel addressing a social need. And then G0022 is an add-on for every 30 minutes after the first 60 minutes. There is no cap or limit to the amount of these services that can be delivered to address the need. But as a Part B service, this would be a continuation of a hospital stay. And there's a process flow that I'll show later, but essentially, if a person is admitted to the hospital, there's social needs that were identified during their hospital stay. As usually many hospitals set up a process to facilitate transitions of care, where there's linkage to either a transitions clinic, a resident clinic, or another follow-up visit. Well, that can be the initiating visit that now provides additional pathways to reimbursement to address the social needs that were initially identified during the hospital stay. This becomes a sustainable pathway to trigger reimbursement directly for addressing the social needs that were part of the screening that occurred during the inpatient stay. Next slide. Principal illness navigation is another care management code that was set of codes that were created for during the calendar year 2024 physician fee schedule. It is also a Part B benefit. But unlike the community health integration, which was specific to addressing social needs, principal illness navigation is specifically for addressing the navigation needs and care coordination for persons who have a serious high-risk condition, independent of a social need. The examples of serious high-risk conditions are across the bottom, but it's not limited to those, but that gives an example. So diagnoses such as dementia, diabetes, heart failure, mental illness, and substance use disorders are all examples. And in this scenario, a person, let's say this person was admitted to the hospital with complex issues related to their diabetes, and then gets linked to, let's say, a resident clinic, then that follow-up transition visit post-discharge would then be an initiating visit that allows for auxiliary personnel tied to that clinic to provide one-to-one health navigation and care coordination for that person. That services can occur per calendar month, ongoing, as long as they continue to have a need. It's time-based billing, and the auxiliary personnel, their time counts towards the billing. And so, if you have partnerships with community-based organizations that deploy community health workers, that is one pathway where the time of the navigator or community health worker is now reimbursable under a new set of codes, particularly when the need is identified as part of a hospital admission and then extends post-discharge. Now there's a sustainable pathway to cover the cost of the services that are required for the follow-up. Next slide. Under principal illness navigation, I just highlighted some of the services. So coordination of care transitions is a specific service, facilitating access to social services, and coordination of home and community-based services. So those are just some of the services that should be highlighted that are part of this service. Since this is a Part B benefit and hospitals bill Part A, the codes and the rates that I described are not directly reimbursable by the hospital, but through your partnerships with community clinics and for fully integrated health systems that actually have clinics that are part of the health system, this becomes a pathway for direct reimbursement for ongoing interventions to address social needs and navigation needs that were discovered during the hospital admission. Next slide. You see the rates for principal illness navigation are very similar to the rates, the reimbursement rates for community health integration, and the payment model is very similar. It is time-based billing. There is a base of 60 minutes. That first code G0023 for that example of a person that was admitted with advanced dementia. And now this person's going to need considerable supports post-discharge. The discharge planner links this person with a transition clinic who does an initiating visit. There's a clinical handoff from the discharge planner to the community-based organization that's going to be working with this person and the transitions clinic. They then do a follow-up transitional care management visit, which is an initiating visit for ongoing community health integration and principal illness navigation. That community-based organization in this fictional example deploys a community health worker to then do home visits, to follow up with the family, provide intensive navigation and supports. And then that information is shared in a bi-directional manner with the other members of the clinical team. All of the time spent would be fully reimbursable based on these new codes. Someone posted in the chat, can I clarify from the reimbursement table that the money goes to the CBO who did the initial intake? So just to be clear, these are Medicare rates. And the HCPCS codes that are listed are HCPCS codes that are billed by an eligible provider. The eligible provider would be a physician, nurse practitioner, or non-physician provider, such as a nurse practitioner or physician assistant. However, the rules that establish these codes specifically stated that auxiliary personnel to the provider that operate under general supervision can provide the intervention. And the time would be aggregated and then billed under the provider that is rendering the general supervision. So the reimbursement would go back to that provider, but through a third-party contract with a community-based organization, which was specifically listed as allowable in the rules, there would be a pathway for payment back to the community-based organization that extended the personnel to address these needs. So the payment would not go back to the community-based organization, but through a third-party contract between a provider, a Medicare Part B provider, and a community-based organization, it would allow for sustainability. Someone asked, does it have to be an outpatient provider? Or can the hospital provider order it? So there has to be something called an initiating visit. That initiating visit by the rules cannot be a hospital inpatient visit, SNF, cannot be a hospital inpatient visit, SNF visit, or an observation stay. So there would have to be this link back to an outpatient provider that would require that initial order or initiating visit. But it could be recommended by a hospitalist or intensivist that was managing this person in the inpatient stay and doing a clinical handoff using the communication techniques that are recommended by the team steps. There would be this handoff to the outpatient provider and the CBO that would then extend the follow-up into the community that triggers the reimbursement. Someone asked the hospital submit the claim. So it is a Part B. Hospitals bill under Part A, but through your relationship with Part B providers, particularly since many hospitals have set up like a transitions clinic or have a resident clinic that is linked to the facility, but bills Part B. And it would need to have that triggering Part B payment. So there would need to be this planning and discussion about what would a recommended process flow be for our hospital that links persons who have social needs back to a provider that can trigger an initiating visit and then allow for ongoing follow-up post-discharge under these new codes that then facilitates a sustainable revenue stream specifically for addressing social needs. And someone asked, what if a civic organization is involved, like a licensed community social worker that is part of the city? So there is a pathway for licensed clinical social workers to provide some of these services. And there's another companion set of services called health behavior and assessment intervention that allows reimbursement directly through licensed clinical social workers. That would be a different workflow. And if people had questions about those, we could provide that. We did later on in the presentation. I do have a sample workflow. It doesn't include the licensed clinical social worker component. That would be a little different. Yes, someone said you almost need a flow chart, and I'm going to show one. So if we go on to the next slide, just wanted to get an opportunity to catch. So this is a process flow, and I've worked this process flow with a few different providers. I am also going to post it in the chat so that you would have an sorry, I'm trying to multitask. So the process flow before you is in the chat, and it gives an example where there's screening during on admission. We're completing the health-related social needs screen. We're identifying social needs during the admission. And then the discharge planner is working with the patient to identify linking that person to community resources. When that person is then linked to community resources, they are also linked to a post-discharge follow-up appointment by an outpatient provider. I list examples of that, like I've said earlier, the resident clinic could be one. Some organizations have a heart failure clinic where they're linking their heart failure patients to organizations that have like a family practice residency program that's linked with the hospital. Those are all examples. There, I have also worked in examples where they partnered with an FQHC, and the FQHC then provides this transitional care post-discharge because of their expertise in addressing social needs. They're really focusing those persons who have a positive screen for social needs to link back there. And so you have this process flow, and this is one example. And this one example, I've worked with a few different health systems that are now implementing this, but you can take this as a canvas to begin customizing your own workflow based on resources that you have at your disposal. Looks like Jeff said, how do you know if a hospital has billed this code if your medical group ACO is not affiliated with that other hospital? So that is a good point. These codes, only one provider can provide these services per beneficiary per calendar month. So there does need to be this discussion with the beneficiary. Most beneficiaries know if they have significant social needs and someone is assigned and working with them, then they probably know. But these codes are new. We're now in March. The codes just began in January, and it's a very low likelihood that there's broad use of the codes already. And as a comparison, if you're familiar with the outpatient billing, and I know we have some ACOs on, the chronic care management codes, they were initially implemented in 2015, and then they were updated in 2017. And there was ASPE did an evaluation of the utilization of those codes. These codes are developed under the same framework or chassis as the chronic care management codes. And the data from CMS shows that only 4% of eligible beneficiaries receive at least one chronic care management service in the calendar year of 2019 when this evaluation was done. So those services, and we anticipate these services will be wholly underutilized. And so there's more concern that we're not leveraging these codes to provide a payment method to address social needs versus concerns that there's too many people doing the services if we use the chronic care management codes as a frame of reference. Next slide. And so I tried to capture some of the questions in the chat. I'd be open to fielding other questions as time permit before we go on to the next section of the presentation.